Now I can invite Dr. Patil, and he is going to speak on assessment of the mitral valve.
Uh, Good evening, everybody. I would like to thank Dr. Muralidhar for this opportunity. I hope everybody is able to see my slides on the screen. I'm talking on assessment of the mitral valve by transesophageal echo. Before I start the actual assessment of the mitral valve by transesophageal echo, I would like to talk a little bit on the mitral valve anatomy. The mitral apparatus actually consists of the left atrial walls, which is an important part of the mitral apparatus, then the mitral annulus, the mitral leaflets, there are two in number, the anterior and the posterior mitral leaflets, the chordae tendineae, the papillary muscles, and in fact the LV walls which support these papillary muscles. I'll not go into too much of detail regarding the anatomy of the mitral valve. Actually, we have two leaflets. That is the anterior mitral leaflet and the posterior mitral leaflet. The AML is a much larger one, covers the two-thirds of the surface area of the mitral valve. And the posterior mitral leaflet accounts for two-thirds of the circumference of the mitral valve. And each leaflet has got distinct scallops or segments. Actually, the posterior mitral leaflet has got distinct scallops, which are separated by some indentations in between, and the area in corresponding to those scallops of the posterior mitral leaflet are divided in the anterior mitral leaflet into segments for the purposes of description or identification. So the posterior mitral leaflets has got three distinct scallops, namely the P1, P2, and P3, and the anterior mitral leaflet has got three segments, that is A1, A2, and A3. But in this diagram, if you can see, the mitral valve is in close relation to the aortic valve and the tricuspid valve. In fact, the anterior mitral leaflet is in close relation to the non-coronary cusp and the left coronary cusp for the aortic valve. Meaning to say that any surgical interventions in the area of the aortic valve can, in fact, lead to some damage on the anterior mitral leaflet or vice versa. Anything can happen on this. So we need to understand the relationship between the aortic valve and the anterior and the anterior mitral leaflet. Now, coming to the chordae tendineae and the papillary muscles. The chordae tendineae are three, the primary, the secondary, and the tertiary chordae, where the chordae tendineae arise from the respective papillary muscles and get attached to the tips of the papillary muscles, which is the primary, the body of the leaflets, that is the secondary chordae. And in fact, the tertiary chordae do not arise from the papillary muscles, but they arise from the left ventricular wall and get attached to the base of the posterior mitral leaflet only, not the other leaflets. And coming to the papillary muscles, I already told there are two papillary muscles which arise from the respective walls: the anterolateral papillary muscle and the posteromedial papillary muscle, and they give rise to the chordae tendineae to the respective portions of the leaflets, the anterior and the posterior leaflets. Now, actually, looking at the 3D shape of the mitral annulus, it is basically a three-dimensional structure which is saddle shaped. Uh, Saddle shape. Now, actually, it has got two axes, the major axis and the minor axis. The major axis is along the intercommissural line, that is in between the anterolateral commissure and the posteromedial commissure. And this is best seen in the mitral midi-esophageal commissural view. And the minor axis, actually, that is a short axis, is actually seen in the midi-esophageal long axis view. Long axis. These are the two axes which we report. In this, the major axis is the most important, that is, which is seen in the midi-esophageal commissural view. Now, actually, in systole, when the heart contracts, actually the saddle-shaped annulus takes the shape of a saddle only in systole, but in diastole, when it expands, it takes the shape of a planar-shaped circular. The annulus becomes more circular, but in systole, it becomes saddle-shaped. Now, the size would be about 29 plus or minus 6 millimeters in end diastole. It's basically a dynamic structure which changes its shape and cycle during each cardiac cycle. Okay. Now, dilatation of this annulus may lead to loss of its saddle shape, which may lead to mitral valve dysfunction depending on whichever the disease it is. Now, in order to orient ourselves regarding the mitral valve, I would say that we need to understand these four views. One is the anatomical view for representation purposes. That is, we can easily identify the structures if we are able to understand the anatomical view. Then is the TOE view. Then third is the surgeon's view. And last is the epicardial view, when sometimes we are not able to introduce a TOE probe in any patient due to some contraindications. The epicardial view is the most important to analyze the mitral valve. Now, analyzing the anatomical view, to make us understand the anatomical view, we have the anterior mitral leaflet on the right side of the screen and the posterior mitral leaflet on the left side. We have the A1, P1 on the top, A2, P2 in the middle, and the A3, P3 lower down. Okay, this valve is viewed from the base of the heart behind the valve. Now, the patient's left and right corresponds to the observer's right and left. The anterior posterior leaflets appear in their appropriate position. Now, coming to the surgeon's view. Now, you see the 3D picture, and we have the surgeon's view diagrammatic representation on the left side. Then, actually, we have the surgeon usually stands on the right side of the surgical table, and we have the anterolateral commissure to the surgeon's left, and the posteromedial commissure to the surgeon's right, and we have the A2 P2 segments in the center. So this is the surgeon's view. That is, when he opens the AV groove, the surgeon's valve sees the valve like what is seen on the 3D. This is the 3D view of the mitral valve with the aortic valve on the top. This is end-face view. The TOE, now rotating the anatomical view, then we see when we advance the TOE probe into the gastric area, we come initially to at the base of the heart. The ultrasound beam cuts across both the leaflets. That is, on the right side we have the posterior mitral leaflet, and the left side we have the anterior mitral leaflet, with the anterolateral commissure of the A1 P1 down below, which is more anterior, and the A3 P3 segments, which is more posterior. This is the TOE view, what we have shown on the left side, and the diagrammatic representation is seen on the right side of the screen. Now, like I said, in contraindicated patients wherein we can't induce the TOE probe, we have the epicardial view, placing the probe on the heart, directly on the heart, after taking all the necessary precautions. Actually, in this is actually the reverse of the surgeon's view, what we can see. Now, actually, what we are saying is, the surgeon's view, we have the A1 P1 on the left of the surgeon and the A3 P3 on the right of the surgeon. In the epicardial view, we have the anterior mitral leaflet on the top and the posterior mitral leaflet below, but the A3 P3, the posterior middle commissure, is seen on the left, and the A1 P1 segment is seen on the right. This is actually the reverse of the surgeon's view, normally what we see on an epicardial view. Now, coming to the views for the mitral valve assessment. Now, we'll come to the 4-chamber view. Now, actually, in the 4-chamber view, if you look at on the left side of the diagram on the left side, the scanning angle is at 0 degrees. That is, it cuts across the A2, P2 segments, and also it cuts across the anterior septal leaflet and the anterior or the posterior leaflet of the tricuspid valve also. But what we need to understand is the A2, P2 segment is seen at the point of the segment the ultrasound beam cuts across. On the mitral side, we see the A2, P2 segments, and on the left side, we see the septal leaflet of the tricuspid valve. But this is when it is in the neutral position. Actually, the anterior mitral leaflet is at a much higher level compared to the septal leaflet of the tricuspid valve. So the distance between the septal leaflet of the tricuspid valve and the anterior mitral leaflet is about 2 to 2.5 millimeters. That we need to understand. Then this is actually the 4-chamber view, what we call it as. In the sense, I'm saying the septal leaflet of the tricuspid valve is a little bit apical compared to the anterior mitral leaflet. This is the position, what we see. Okay. Now, in the same 4-chamber view, suppose you withdraw the probe, it cuts across the A1 P1 segment. That is in the 5-chamber view. Okay. Now, if you advance the probe back into its neutral position, then it cuts across the A2 P2 segments. That means, how do we say it is A2 P2? Is you have the septal leaflet little bit lower and the anterior mitral leaflet little bit higher. That is, the septal leaflet tricuspid valve is more apical compared to the AML. Now, if you advance the probe further or more posteriorly, the ultrasound beam cuts across the A3 P3 segments. Now, how do we recognize the A3 P3 segments? Is once you advance the probe more posteriorly, we have to understand that the septal leaflet of the tricuspid valve and the anterior mitral leaflet arise at the same level. They are occurring in the same line. There is no distance between the AML and the septal leaflet of the tricuspid valve. Only then we can understand it is at the more posteriorly or the A3 P3 segments. What I mean to say is, in one single view of the 4-chamber mid-esophageal view, we can analyze all the segments of the mitral apparatus. That is what I mean to say. Now, this is what we are seeing here is, now if you look at on the left side of the screen, this is the A2 P2 segments. You can see the septal leaflet a little bit lower compared to the other leaflet, and the zoomed view you can see on the right side of the screen. I think everybody can appreciate the septal leaflet being a little bit more apical compared to the AML. Now I'm going to the next slide. Now here, when I withdraw the probe, you can see the aortic valve in the center. This is the A1 P1 segments because it is more anterior. Okay. This is the A1 and the P1 segments of the mitral apparatus. Now, when I advance it more further, more posteriorly, if you can see, suppose I am able to freeze this, If you can see, the AML, the A3 and the septal leaflet of the tricuspidula are occurring at the same level. I hope everybody is able to appreciate that. Okay, this is to tell you that this is the ultrasound beam is cutting across the A3P3 segment of the mitral valve. Now we have one interesting finding I have to present to you. The four chamber view demonstrating the A2P2 segments. And if you see here, the jet, the MR jet is more directed posteriorly. But if you can see, appreciate, there is some segment popping up behind the A2 segments. So we need to understand what is the segment which is prolapsing. Is it only the that meaning to say, because the jet is directed posteriorly, the anterior leaflet is involved. Definitely there is something prolapsing from the anterior mitral leaflet. Now we need to understand what is the segment which is prolapsing behind the A2 segment of the anterior mitral leaflet. The best way to diagnose that would be through a 3D. Now 3D, if you look at this, this is actually the surgeon's view or the 3D view of the mitral valve. You can see it is actually the A3 segment of the anterior mitral leaflet which is prolapsing. This is from the LA aspect, the view, and if you see on the LV aspect, you can see it on the left side on the screen. So it is actually, whenever in the four chamber view, if you see anything prolapsing behind the A2 segment, it's usually the A3 segment which is prolapsing. So we need to understand and give a correct diagnosis regarding the prolapsed segments to the surgeons so that the appropriate surgical corrections can be taken up. Now coming to the mitral commissural view. Now if you look at the diagrammatic representation here, at the angle of 60 or 70 degrees, if you see the ultrasound beam, you see the red line, it cuts across P1, A2 and P3. That is from right to left, I'm reading the scallop, that is P1, A2 and P3. This is what are the segments which are seen in the mitral commissural view, P1, A2 and P3 from right to left. Now, important thing is here, now even in the mitral commissural view, we will be able to diagnose or analyze all the segments of the mitral apparatus. That will be depending on the probe movements what we do. Suppose in the mitral commissural view, if we are able to rotate the probe in a clockwise fashion, if you rotate it gently, see the rotation has to be in millimeters, not even in centimeters. If you rotate it in a clockwise fashion, if you see the ultrasound beam will cut across A1, A2, A3 segments. It cuts across only the anterior mitral leaflet in the mitral commissural view also. Suppose from the neutral position, if you rotate the probe little bit anti-clockwise, it cuts across P1, P2, P3. The entire posterior mitral leaflet is scanned. And if you come back to the neutral position, it cuts across P1, A2, and P3. I hope everybody understood these movements of the probe, which are very important to diagnose. I'm not saying by 2D you cannot diagnose anything, but 3D is a very, very important this thing. But many of the centers do not have a 3D facilities. Probably by 2D itself, we can analyze the abnormalities in the mitral valve by these delicate probe movements, which has to be done in millimeters, but not in centimeters. Now, actually, another important thing in a mitral commissural view is, suppose this is one of the views I'm trying to show, that is, if the P2 scallop prolapses in a mitral commissural view, normally it prolapses and it pops up behind the A2 segment of the mitral valve. That means it appears as a cobra head behind the mitral valve. I'll show you the image of that. If you can see here, it is prolapsing behind the A2 segment. So if you see a cobra head appearance of the mitral leaflets in the mitral commissural view, it is usually the P2 prolapse. It is definitive and very confirmatory. And of course, on the right side, if you can see in the 3D, you can see the P2 prolapse with the flail segment, which is seen there on the right side. Okay. Now, this is another view wherein in the mitral commissural view, you can see this is the P3 segment, which is flail. This is one of the views to show you the flail segment of the P3 segment. Now coming to the midi-cervical two-chamber view, here the ultrasound beam scan cuts across the whole of the anterior mitral leaflet and the portion of the posterior mitral leaflet. That is, from right to left, if you want to read the scallops or the segments, it is A1, A2, A3, and the P3 segment. This is the two-chamber view, which is accessed at 90 degrees angle. Now, the midi-cervical long axis view. This is one of the important views to assess the mitral valve, wherein in fact the gradients across the mitral valve can also be taken effectively in this view. Normally at 120 degrees or 110 or 120 degrees, it cuts across this is at the minor axis, like I already told you, it cuts across the A2 and the P2 segments of the mitral leaflets. Now, the same movements of the probe can be done here. In the sense, if you do a clockwise rotation of the probe, probe, it cuts across, the ultrasound beam cuts across the A3 and the P3 segments and the coronal sinus. Okay, and turning the shaft of the probe in an anti-clockwise direction or turning the probe to the left, it cuts across the anterior or the anterolateral commissure, that is A1 and P1 segments of the anteromitral leaflet, A1 of the mitral valve, and the left atrial appendage also. So probe movements also effectively can be done in the mid to long axis view. Okay, now I'm showing you another view. Now actually this is a long axis view. Normally we say it is the A2 and the P2 segments, but I would know because I have done the probe rotation. That is, with clockwise rotation of the TE probe, I would definitely say this is the P3 scallop which is prolapsing. I'm not saying in the neutral position this is not seen, but important is we have to understand that the degree of prolapse becomes more prominent in whichever segment it is prolapsing. Suppose it is actually a P3 prolapse. If I do a clockwise rotation of the probe, the prolapse becomes more significant. And if I go back to neutral position, the prolapse is not so effectively seen. That is what I meant to say. I hope everybody understood the rotations of the probe. Of course, this is a transgastric basal short axis view, like I already said. That is, on the right we have the posteromitral leaflet, and the left we have the anteromitral leaflet with the anterolateral commissure down below anteriorly, and in the posterior segment we have the A3 and the P3 segments at the posteromitral commissure. This is the basal short axis view, transgastric basal short axis view. Now the transgastric two-chamber view. Here we have the anteromitral leaflet below and the posteromitral leaflet. Here the ultrasound beam cuts across from below to above A1, A2, A3 and the P3 segments of the mitral valve. Now coming to some important points during transvascular echo, I think we can use the anatomical view of the mitral valve to orient ourselves and identify the commissures and segments of the mitral valve by doing the rotation and movements of the probe. One. Second is the segments of the mitral valve are read preferably from the right to left of the image. Okay, and we need to understand that A1 P1 is the anterolateral commissure and A3 P3 is the posteromedial commissure. Thank you very much.